Good afternoon, everyone. COE STM welcomes all the participants for today's RDLS session. Today's topic is revised guidance on TPT for PLHIV under NACP, and the speaker is Dr. Nivedita Datta. Dr. Nivedita Datta ma'am has completed her MBBS and MSc in Clinical Research and Regulatory Affairs (PDCR), is presently working as Senior Medical Officer, Clinical Research Fellow at the Center of Excellence in HIV Care at the School of Tropical Medicine, Kolkata. She is actively involved in various HIV-related research projects and has attended conferences and published articles in international journals in the relevant field. We welcome you, ma'am, for today's session and request you to start the session.
Thank you, Sweta. Am I audible?
Yes, ma'am.
Okay. Thanks for the introduction. My topic of discussion today is the revised guidance on tuberculosis preventive uh, therapy, or TPT as we call it, under the National AIDS Control Program. Now, why is this topic so important? Like, we keep talking about the tuberculosis preventive treatment, and at present we are also prescribing the 1 HP to our patients. So we need to really understand why the National Tuberculosis Program, the NTP, is so worried about the preventive treatment. Now, basically, India has the highest estimated burden of tuberculosis infection globally, with nearly 35 to 40 crore Indian populations having the latent TB or the exposure to TB, of which we find that usually annually a huge number of people turn out to be positive. Like, if there are 35 to 40 crore Indians who are exposed, even if it's a 5% of the exposed are having tuberculosis in the next 2 years, so that is a huge count. So the risk of TB disease after infection depends on several factors, as we know, and one of the major factors is immunological status of the subject. So the immunological status, we know that it depends on several issues like the diabetes. The things that can affect the immunological status is diabetes. One is the HIV infection, other virological infections, and also the carcinomas. So what we like, the risk of having HIV, the TB, the disease increases by 25 times among the contacts of the bacteriologically confirmed TB patients compared to the general population. Now, this is the reason this topic is so important, because the prevention of TB disease is very critical, and it is a strategic plan for the NTEP, National Tuberculosis Elimination Program, to end TB by 2025. The strategic plan targets to treat the prevention, that is the latent infections. We are all exposed to TB bacilli, and if I fall in the immunocompromised group of patients, as I said, or subjects, then ideally I should be given a short course or a long course of preventive therapy. So overall, why I am talking about this is important, because we need to eliminate the latent tuberculosis, because it has been seen that by 1 or 2 or 5 years, the chances of having TB, the florid TB, increases. Now, who should be offered TPT, when to start, what TPT regimen to be given, how to monitor and how to report. These are the outline of my discussion. Now, why tuberculosis preventive treatment? As I said, that it consists of a course of one or more antitubercular drugs given with the intention of prevention. That is, we are exposed to the tubercular bacilli when we are having contacts with the microbiologically confirmed sputum positive TB. And then if I am exposed to one such patient, or I'm exposed to one such neighbor or any household contact, I also develop the high chance of having tuberculosis in the next 2 years. So to curtail of that, prevention is important. So we are giving it the TPT or the prophylaxis to people who are infected with TB bacteria, or have been exposed to it, or at a higher risk of developing TB disease. There is a huge difference with infection and disease. The first point, as I said, is infection. So I am infected with TB bacteria. I have been exposed to TB bacteria. But that does not mean that I will be developing the disease. I am at the risk of developing disease because I am exposed to it. Okay, and the TPT is considered one of the most critical public health measures to protect both individuals and the community from TB. As I said, India has the highest estimated burden of tuberculosis infection globally. And so, apart from early diagnosis and treatment of the active TB cases, it is also important that we start treating all our exposed people so that these exposed people with the seedlings of tuberculosis bacilli in them do not lead to a florid disease. TPT is one of the key interventions to achieve the end TB targets, as I said, with the target of ending TB by 2025 as the national strategic plan. We need to aim at prevention also. Now, why TPT in PLHIV? The risk of developing active TB disease among PLHIV is 16 to 21 times higher than those without the HIV infection. This has been seen by WHO and it has published in February 2021 by WHO TB Consolidated Guidelines. It says that the patients who are having TB and HIV at the same time, then the tendency or the chances of having a florid TB disease goes up by 16 to 20 times. TB is the leading cause of morbidity and mortality among the people living with HIV. With TPT, the risk of developing TB disease decreases by up to 90% among PLHIV. So, TB, as we all know, we all our physicians are working at the ART centers. We know that one of the deadliest of the co-infections is TB, be it PTB or EPTB. And we also know that the risk of developing TB diseases decrease by up to 90% among the PLHIV if we are getting the prophylactic treatments. These have also been documented in the Temprano study. Now, how does the TPT work? This is very interesting. Like there are like usually we keep on giving the patients, but as physicians we need to understand, or as a part of the ART center, the group of staff we have, we need to understand that why do we really give one or two drugs as the prophylaxis, and how does it help? So the drugs which we give is usually a antibacterial which is working against the Mycobacterium tuberculosis bacilli. What it does, it boosts the interferon alpha response. It's usually INF alpha. And what is INF? It is a cytokine that is released by the innate immune system. It detects viral infection. It stimulates the lymphocytes to kill the target cells. So what happens is, if I have a huge load of interferon alpha in my body, I I am able to kill all the viruses, most of the bacilli that are entering my body. So it boosts my immune response. Now inhibits the synthesis of the mycolic acids. If we remember our microbiology days, the mycolic acid is a very key cell wall component of the bacterial cell wall. So the synthesis of mycolic acid is very important for the bacteria to replicate or multiply. This is inhibited by INH or isoniazid. Accelerates the sterilizing activity. All the bactericidal drugs like rifampicin and the pyrozinamide, they are having a sterilizing activity. That is the rate at which a drug kills the tuberculosis bacilli is very high. It kills the tuberculosis bacilli very fast. And because of this fast killing, the bacilli are not able to mutate. As a result, the persisters that survive the usual treatments are also killed. If I am clear, what I mean to say is with the bacteriostatic drugs, the bacteria are killed. But the bactericidal drugs, what they do is their killing capacity or the rate of killing is very high. When the rate of killing is very high, the bacteria do not really get that chance of mutations or resistance. So the reservoirs or the persisters that survive any course of treatment are also killed. This is known as the sterilizing activity. This is done by the prophylaxis by rifamycin or rifamycin group of drugs. Now, inhibition of the translational adaptation by directly binding to ribosomal protein S1. We all know that when we are giving a drug, what happens is the bacteria or the virus itself, it also undergoes a translation. That is at the when I am killing a bacteria or a virus, that bacteria or virus undergoes some ribosomal translations, that is, changes in its protein. That is called mutation. This mutation is inhibited by drugs like pyrozinamide. That is the translational mutations, that is the mRNA assisted mutations are inhibited so that the drugs are not able to uh, grow resistance against the usual group of drugs. So these are the this is very interesting, and this is how we eliminate the TB bacteria by giving the prophylactic treatment. But again, we have to think that TPT will only work if the patient does not have any evidence of active TB disease. Because as we know, with the active TB disease, we usually give 3 drugs for a long time and another 2 drugs, 4 drugs for a long time and another 3 drugs for the rest of the period. So what happens is, if I have treated my TB infected patient, frank TB patient, with a single drug or 2 drugs, that is, I am leading to some point of resistance. Now, the historical background of TPT is important. In the initial days, around 4 to 5 years back, we were having those 12-month or 18-month prophylaxis regimens. Then we shifted to the 9 or the 12 months parts of the world, and we now have the INH and rifampicin group of drugs, that is rifampicin. Now, the TPT duration has now been reduced to 1 HP, that is the INH and the rifampicin, for only 1 month. The reason for all these changes basically is, uh, down the years we have seen that for the last 2 to 3 decades it has been shown that
Ma'am, we have lost audio.
I
Yeah, the
think
screen is visible.
I was not audible from this slide.
Right.
Yeah. So over the last few decades, it has been seen that the prophylaxis treatment has also gone through a huge evolution. Initially, the prophylaxis for TB ranged from 12 to 18 months. Then over the years, it has been reduced. The duration has been revised, and the target has been to give a shorter course and uh, gain a better outcome, because longer courses of treatment usually have poor adherence, and the issue is, again, with poor adherence the chances of resistance crop up. So now we have come down. There are mostly 3 popular prophylaxis regimens that are going on around the world. One is the 9 HP, one is the one is the 9 INH, 9-month INH, another is the 6-month INH, one is the 3-month INH with rifampicin, that is the weekly courses. And now recently we have the 1 HP, that is the rifampicin and INH for only 1 month. So this duration has reduced, and the purpose of reducing this duration are many. Here we always find that if we can reduce the duration, the adherence improves, and usually the patients do well with a shorter course of treatment. Now, the incidence of tuberculosis in the PLHIV after IPT in India. So, studies have been done by ICMR. The effective study shows that with only ART and no TB prophylaxis, the outcome of incidence of new cases of TB was around 2.42 per 100 person years. Now, this person years is something like it's it's a number of people into the time each took the medicine. That is how we calculate the person years. So the incidence of TB has reduced drastically from 2.42 to 0.6 with the IPT courses. That is here the study was done with the INH for 6 months. So the ICMR had a multicentric prospective study, and this really showed that there was a significant amount of reduction of TB in PLHIV with IPT. But there were also a few side effects, like 3% had to discontinue due to the adverse drug reactions, and the completion rate was 89%. As I said, because it's a 6-month regimen, the issues of adherence also crop up. So, but the important take home message is, when a patient was only on ART and with no IPT, no prophylaxis for the TB, there were incidences of 2.4 cases per 100 observed person for 1 year. That's how we interpret the 100 person years. And with the use of IPT, that 2.4 dropped to 0.6 per 100 observed cases in 1 year. So, who should be offered the prophylaxis for TB? We have a question here. Um, will it be CLHIV less than 10, CLHIV less than 12 with contacts, pregnant and breastfeeding, PLHIV with CD4 less than 200, and none of the above? Who should not be offered TPT? Sweta, I'm moving ahead with the answers
Yes,
myself.
yes, ma'am.
Yeah,
Yes, ma'am.
that will help. Basically, none of the above is the right choice, because mm, we will be offering a prophylaxis for all age groups above 1 year of age. Okay, so apart from the infants, we will be giving a prophylaxis to everyone. And also for the infants, we will be giving a prophylaxis if that infant or that child under 1 year of age is having a positive contact history. So there is no bar about CD4, no bar about pregnancy, breastfeeding. All should be offered TPT. As I said, we have a huge burden of tuberculosis, and we really need to eliminate the latent infections in our bodies. Now, who should be offered TPT? Adults and adolescents, all. Children aged more than 12 months, as I said. Above 1 year, all should be offered. Only the infants, that is up to 12 months of age, they will be given a prophylactic treatment if they have been exposed to a positive case. That is, if the mother turns out to be a positive case, or if the father or any very close family member. Additionally, children who successfully completed TB treatment for they will be given secondary prophylaxis. Now, the only things that we need to remember in mind is, we have to rule out the TB disease before offering a TPT, because as I said, TB treatment for active TB disease is a 4-drug or 3-drug regimen for a prolonged period. Giving a single drug might turn out to be dangerous. And regardless of the ART treatment, pregnancy, previous TB treatment, immunosuppression, and the availability of testing, TPT should be offered. Now, the availability of the test for TB infection, this is something I would like to elaborate on. Uh, Often we find that people are asking us that, really, how do I understand that I am prone to have TB? We have two tests for that. One is the IGRA test, or the interferon gamma release assay test, as we know. Another is the tuberculin, that is a sensitive test. So these two tests, one is a skin test, the TST we all know, we usually do it for frequently in children. These are the two the tests that help us to understand who are the latent TB infections. That is, a person is not diseased, but he or she has the tubercular bacilli in them, which is shown by the skin test or the uh, IGRA test. Now, it has been seen in several studies that the capacity of the IGRA to detect the latent TB infection is lower, that the percentage of detection by IGRA is lower than that of the tuberculin skin sensitivity test. Okay. So preferably TST has to be done, and IGRA is not that much preferred. Now, the second quiz is about a test for TB infection is not a requirement for initiating TPT among PLHIV. It is not a mandatory test. It can be done by a person who is curious to know about his status, but it is not mandatory. So it is really not required, and the answer is true. Now, how to rule out the TB disease? So, as we all know that we have the four symptoms of cough, current cough, fever, weight loss, or night sweats, and along with that, for children, we always replace it with the history of contacts and the poor weight gain, because weight loss is difficult to elicit, and also the history of contact is taken instead of the night sweats. And now coming to the infants less than 12 months also, here also we have to give should receive TB preventive treatment, as I said, who are in contact with the person with the TB disease. Now, coming to the four symptom screening, we have the adults and the children. Uh, for adults, we have the four symptoms like the current cough, fever, weight loss, and night sweat. For the children, we have poor weight gain, fever, current cough, and the history of contacts. If the four symptoms are positive, we have to investigate the patient for with the CBNAT, sputum, or the direct microscopy, a chest X-ray, or an ultrasound of the whole abdomen. Then we have, if the symptoms are not in favor of 4S, then we have to assess for any other contraindication to TPT, like any poor adherence to the ART, poor adherence to other group of drugs, then liver disease, alcoholic, these also need to be ruled out, and then we will be prescribing TPT for that patient. Now, investigations, if we find that with investigations the patient is positive for TB, we straightforward go to the TB treatment. Not positive for TB, but if we are suspecting, we can follow up that person for a few weeks. And if we have any other diagnosis, we'll consider TPT with the relevant treatment. Now, ruling out TB, how do these four symptoms help? As per the table, we see that the sensitivity and the specificity of these tests alone is not that high. But when we look at the negative predictive value of the tests combined together, then what happens is if the four symptoms are combined, the negative predictive value, what is the NPV? Basically, how much am I able to say with confidence that this patient does not have TB? Okay, so if the four symptoms are all negative, I can conclude 98.5% of the times that my in 100 cases that this patient is or this subject is not having active TB. Similarly, with the other symptoms, that is hemoptysis, night sweats, and the weight loss, we see that basically the predictive value, negative predictive value is highest with the cough and the fever, night sweat, and the weight loss. With hemoptysis also, the predictive value is also quite high. Now, the take-home message is if we can screen our OPD patients for all these four symptoms before giving the TPT or the prophylaxis for TB, it would help us to understand or rule out or exclude the cases who are having active TB. And we can rule it out to an extent of 98.3 to 98.5%. Now, when to start TPT? The third question is what is the optimal timing to initiate TPT among PLHIV? It is neither 3 months or with the CD4, no relation with CPT and all. Usually we ask advice to start TPT and ART at the same time. Now coming to the greater TB risk reduction with the combined ART and TPT. Now as with our ICMR study, it has been seen in several studies worldwide and published in the AIDS journal also that the IPT alone gives a percentage of reduction, but the ART and IPT, when they are combined together, the protection increases to 80%. So the reduction of having a TB frank disease goes up a significant level. In South African countries, it has been seen that giving only IPT, that is ruling out only latent tuberculosis and not starting the ART, does not help. So only starting ART and not giving IPT also does not help. So the combined use of TPT and ART is associated with the restoration of tuberculosis specific immunity and has shown to benefit the both TB prevention and mortality, particularly among the PLHIV with the advanced HIV disease. As I said in my previous slide, the reason for giving ART and IPT together is ART, as we know, with the killing of the viruses, our innate immunity starts improving. So our cytokines and our CD4s, they improve. And the improvement of the cytokines and the CD4s, they also contribute to the efficacy of the IPTs. So they go hand in hand. If I give IPT to a patient who has a poor immune status, the IPT doesn't work well because that patient's innate immunity, that is the cellular immunity, is not that good. Again, if I am giving ART alone, it really works with the CD4 and the innate immunity. But IPT, if given after at the same time or after 1 or 2 weeks, it goes hand in hand. ART plus IPT in Botswana study, we have seen it improves it reduces the chances of having a TB frank disease by 97%. So when should TPT be initiated? Newly registered patients, we will start TB and prophylaxis and ART at the same time. It is also the discretion of the physician who is treating the patient. If he or she feels, she can start TPT after 2 weeks at the most, because often it is like we do not have our normal LFT report is not available at the time we are starting the TLD first line. So if you want to really assess the patient's status by looking at the LFT report or just going through the history and the past records, so deferring for 2 weeks is allowable, and by that time we really need to start IPT again. And PLHIV already on ART, they should not be kept waiting, and we will be giving them TPT at the earliest. Now, the contraindications to TPT is active TB disease. That's an absolute contraindication because an active TB disease needs 4 drugs or more drugs if the patient is resistant to INH or rifampicin, and we should never give IPT or TPT, as I said, to the patients who are suspects of active TB. We have to rule out active TB. We have to screen that patients with sputum, chest X-rays, and USG, whatever tests are available. And we will not be giving IPT or TPT to this group of patients, because that will what will happen is the tubercular bacilli, instead of being given the full course of 4 or 5 drugs, it will be treated by only 1 or 2 drugs, and that will render more resistance. Now, active hepatitis is another issue, because we know INH, rifampicin, especially pyrazinamide, are all hepatotoxic drugs. So active hepatitis is something that needs to be stabilized, need to be observed, need to be evaluated, and only then we will be giving TPT. Regular and heavy alcohol consumption is an offender to lead to hepatitis, as we know that patients usually have a damaged liver, so we will think twice before giving TPT. Signs and symptoms of peripheral neuropathy, because INH induced neuropathy is a very high, it has a high prevalence, and it's a disturbing issue with the patients. Usually they come with the complaints of persisting tingling, numbness, and paresthesia of the extremities or the limbs. So if a patient already has a symptom of peripheral neuropathy, we will not give TPT to that patient. And who have completed DRTB, that is the drug resistant TB treatment, they are also not eligible to get TPT, because they are eligible to some extent. I'll come in my later slides, but not with the schedule INH, rifampicin, or the rifapentin. Now, concurrent use of the other hepatotoxic medications, we need to look into the other hepatotoxic medications. We do not want adjunctive hepatotoxic drugs along with your TPT, and because we do not want liver damage. So good screening of all the other co-medications is important. Allergy or known hypersensitivity. This is also an issue that has been seen. There are 4% or 3% patients who were given IPT or TPT have experienced the adverse drug reactions. And once we have an adverse drug reaction, we really cannot continue TPT or IPT. Now, conditions that have been removed from the list. So basically, previously we used to say that if a patient is not adherent to a cotrimoxazole therapy, it indicates or it reflects that this person will be adherent to another treatment also. But now this has been removed because as per our NTP strategy, we are moving towards the elimination of TB. So that point has been removed, and even if the patient is non-adherent to CPT, we will continue with the 1 HP. We will counsel that patient. Maybe he or she needs more stringent counseling. Poor understanding of the IPT by the guardian, that was also included in the contraindication list, that has been removed. And the context of MDR TB. Now there are a group of drugs that are given for as TPT. So basically, what is important is what we do with MDR TB. We have a group of drugs that we give. So TPT will be given, but not with INH and not with rifampicin or rifamycin group of drugs. Again, assessment of the PLHIV for the tuberculosis prophylaxis treatment initiation. So the assessment should be with the personal history, the history of medication, and the liver function tests. Now, what we do with the personal history, what we need to eliminate is the pregnancy or the contraceptive uses, assess the presence of the comorbidities, substance abuse, alcohol, oral or injecting drugs. So pregnancy or contraceptive use is not a contraindication, but we need to remember that there are drug-drug interactions, and we want our drugs to work. So the list of other drugs is also very important. The history of medication, hepatotoxic medications are like contraindication because or it needs to be basically not a exactly contraindication. They need to be monitored well. When I am having a hepatotoxic drug along with my IPT or TPT, my LFT needs to be observed very closely. Allergy or the known hypersensitivity. Basically, we cannot continue a patient who is having an allergy or a known hypersensitivity to any component of the TPT. Now, the liver function test is not mandatory, but still a baseline test is important to evaluate the changes in the LFT later on. And if the transaminases, that is the ALT and the AST, that is SGT and SGPT, if they go up by 3 times of the upper limit of normal in the presence of the symptoms, or the 5 times of upper limit of normal in the absence of the symptoms, then we have to think about stopping the drug. A clinical decision has to be taken. So if usually we have our SGOT, SGPT are usually around the level of 40, 45 normal values. So if it goes up above 120, 130 with symptoms, or if it goes above 200, 220 without symptoms, then the clinician has to decide, he has to take a call whether the TPT can be continued or not. Now, what TPT regimens are recommended under NACP? what the fourth question is, what is the most preferred TPT regimen for PLHIV more than 13 years under NACP? And the answer is 1HP. 1 stands for the duration, that is 1 month. H is for INH and P is for rifampicin. Now, this is the OM on the revised guidance on tuberculosis preventive treatment. We dated the 20th of May this year. And as per these guidelines, we were advised to start our PLHIV population on the group of preventive drugs. Now, the TPT with 1 HP or isoniazid and rifampicin, as I said, that is a once daily regimen of INH and rifampicin, is given for 4 weeks or 28 days. And this is given for all subjects, all PLHA or PLHIV who are more than 13 years of age, more than equal to 13 years of age. Now, less than 13 is not recommended, as also pregnancy and breastfeeding are excluded, and the PI group of ART regimen cases are also excluded. This is very important because uh, we cannot give rifampicin to these group of people. Now, who are they? One is the PLHIV less than 13 years of age. One is the pregnant and the breastfeeding mothers, and the protease inhibitor group of drugs. Because rifampicin or rifamycin or rifabutin, or these group of drugs, they have a huge drug interactions, as we know, because they are the cytochrome P450 inducers. They induce the metabolism of other drugs, and hence they are not given in certain circumstances, with also not given in the pregnant and the breastfeeding, and in the PLHIV less than 13 years of age. This 13 years of age is important. Basically, rifampicin is not contraindicated in children, because we all know that we usually give the rifamycin group of drugs to children also. But uh, I think probably because of the programmatic issues and the dose and the adjustments, the group under 13 has been excluded from 1 HP. And for under 13 breastfeeding and the pregnant and the patients on the PI group of drugs, we have to as prescribe INH daily for 6 months. Now, coming to the 1 HP, why do we prefer 1 HP? There were several trials, as I said in my earlier slides, that over the past few decades, the treatment for prevention of TB has come down from 18 months to 12 months to 9 months, 6 months, 3 months, and now to 1 month. So several trials have been conducted worldwide, because there were issues when I give a drug for prophylaxis, and when the prophylaxis is extending over months, what happens is the adherence falls. As a result of that, the efficacy falls. Prolonged treatment leads to more side effects, and the prolonged treatments also lead to some other metabolic disturbances. So, like the liver disease and other things. So, it is best that we shorten the prophylaxis for better adherence, for better patient compliance. Tolerability is more as per the side effects, and also the outcome is naturally better. So the brief trial and other trials in Taiwan, they showed that there were a significant reduction of side effects, a significantly more completion rates, adverse events were infrequent, and the TB incidence was also significantly low with 1 HP compared to 9H, 9H or the 9-month 1 INH. So there were several trials, not only the brief TB trial, there were several trials which were done worldwide, and all the trials showed that 1 HP is by way not inferior. That is there's a significant term called non-inferiority. That is by no means is 1 HP inferior than 9 INH. So giving INH for 9 months and achieve by that, what the goal I am achieving is equivalent to what the goal I am achieving with 1 HP for 1 month. So the retrospective study in Taiwan also, it compared 1 HP with the weekly 3 HP. Here also there were similar completion rates, and thus viral suppression was also good in both the groups. Now, the TPT regimen for PLHIV having contact with drug-resistant TB patients. So, what do I prescribe when I have a drug-resistant case? That is a INH resistance. The TPT will be with rifampicin. That is, rifampicin will be given for 4 months. If I have a MDR case, that is a contact with MDR case or rifampicin resistance, what will be the TPT? That will be with the fluoroquinolone, that is levofloxacin, for 6 months. So we really have options nowadays with the resistance group of contacts. So if I have a resistance or a contact with a INH resistant case, then the TPT or the prophylaxis will be with rifampicin for 4 months. If I have a MDR, that is the resistance with INH and rifampicin both or rifampicin only, then the prophylaxis will be with the fluoroquinolone, that is levofloxacin, for 6 months. But proper documentation of the history for TB among the family members or close contacts and the drug resistance of the index TB patient should be done. It is not that I will be giving at random by just by suspicion. We have to document it properly before giving the drug resistance prophylaxis. Now 1HP, a summary as a table, is eligible for all over 13 or equal to 13 years of age, excluding the pregnant and the breastfeeding and the PI based ART. So INH and rifampicin is given 28 days, the duration, once daily is the course. The INH is given in the dose of 300 milligram and rifampicin is given in a dose of 600 milligram. Interactions, it is contraindicated with all the protease inhibitor group of drugs. We have to remember that PIs they are contraindicated because we have ritonavir with the PIs. They are again the cytochrome P450 inhibitors. So we cannot give the inhibitors and the inducers together. So the PI group of drugs are contraindicated. Nevirapine is contraindicated because of hepatotoxicity suspected, and TAF is also contraindicated. Luckily, we do not have nevirapine and TAF in our program. So we have to keep in our minds that all PIs are contraindicated. Those adjustments are not needed with tenofovir, efavirenz, dolutegravir, or raltegravir. And hepatotoxicity, hypersensitivity reactions, rash, GI upset have been seen. Hepatotoxicity and hypersensitivity were the leading causes due to the disruption that led to the interruption of the treatment. And something we really need to remember as ART center counselors and physicians is patients will be having orange discoloration in the urine. Other fluids he might not understand, but the fluid in the that is the urine, discoloration of or the orangish color has to be counseled. There have been instances where patients have stopped 1HP after starting the treatment for 2 to 3 days because of this color change. They thought that they are having the hematuria and they stop the drug. The peak concentration is increased when given with a meal. So 1HP is the drug of choice now for TPT. Now the dose of 1 HP, as I said, is that is INH is for 300 and rifampicin is 600. We have several groups of combinations available and we will be giving as available. Now, coming to 6H, that is only INH for 6 months. We have been giving this, I think, from 2016 onwards. We are well acquainted with the 6-month course of INH. And as I said before, a peripheral neuropathy is a contraindication, and we really have to look into those cases. We have to give pyridoxine in a dose of 50 or 40 milligram. Even if we do not have pyridoxine in a supply from NTP, where a small prescription can save the patient from having these neuropathies. So that's best given to these patients. INH can also cause psychosis, can also cause hepatotoxicity. We have seen patients who have alarmingly high SGPT levels with INH, and the drug has to be stopped abruptly. Now, who are eligible? Basically, all are eligible for INH except the infants. Pregnant and breastfeeding are eligible, is safe with them, and also PLHIV with the PI-based drugs. So INH is comparatively safer. It can be given to a wider group of patients. Now the doses, it's always handy to keep these as a chart, printed charts on the under our tables, under the glass tops. So the it starts from a range of 5 kg till 25 kg, and beyond 25 kg, the patients will be receiving a full dose of INH. Now the 4R, as I said, as the rifampicin 4R for tuberculosis preventive therapy. Here, these are the cases who have INH resistance, and only with resistant cases, after proper documentation, we will give giving rifampicin for 4 months, that is for 120 days. Okay, so basically in pregnant there is no safety data, and hence we avoid in the pregnant. And it is also contraindicated with the PIs. As I said, cytochrome P450 inducers and inhibitors cannot be prescribed together. Nevirapine because of hepatotoxicities, and the TAFs. Now the adjusted dose is needed with dolutegravir. This is very important. So if I am giving the rifampicin as a prophylaxis for 4 months, we have to give dolutegravir to that patient for 4.5 months. Not only 4 months, it is 4.5 months. So 2 weeks beyond the end date of rifampicin. Now the absorption is rapid but may be delayed or decreased by high-fat meals. Now the dosage, again, as I said, needs to be printed and kept under our glass top tables. Now the levofloxacin is a 6-month course given for patients who are having MDR-TB. Good proper history has to be taken. Rifampicin resistance has to be documented, and the fluoroquinolone sensitivity should also be seen into. Not on the PI-based ART. This is again very important. Why? Because atazanavir, as we know, and lopinavir, not all PIs, basically atazanavir and lopinavir have the tendency to prolong QT. That is, the QT prolongation is a side effect of atazanavir and lopinavir. And QT prolongation is also seen by levofloxacin. So if we are giving these two drugs together for a long period of time, there I am exposing my patient to QT prolongation and the dysrhythmia of the heart. So that has to be avoided. This is a 6-month course, once daily. It is safe in the pregnant, and no such other contraindication or drug interaction except for PIs. Now the TPT initiation monitoring, how it should be done. Initiation should be done after ruling out active TB. The proper TPT regimen has to be decided, and the dosage as prescribed by the weight bands. Counseling has to be done, schedule of the medicine to be explained, timing and the follow-up visits. There will be few adverse effects, especially with INH, rifampicin group of drugs. Counseling needs to be done. As I said, rifampicin group of drugs, orange colored urine, orange colored body fluid. Also with the INH, peripheral neuropathy, hepatotoxicity, psychosis. PLHIV should be advised to report back at the earliest if they have persistent nausea or loss of appetite for evaluation of LFT. LFT cannot be estimated, derange LFT cannot be estimated by the patient himself or herself. What we can ask our patients is to look for icterus in the eyes, to look for nausea or a loss of appetite. Okay, and any new or onset of the worsening of symptoms. For 1 HP, entire course of 28 days should be given at a go, and the PLHIV initiated on other TPT regimens, 1 month of dosage along with the ARV drugs, and requested for the monthly follow-up. So we have a NICSHA ID, the enrollment has to be done there also. TPT monitoring is important. Even if I am giving TPT, there may be cases of unmasking, like a patient did not really have a 4S symptom. Those symptoms were not very prominent at the point of time when I gave him or her TPT. So there may be a flaring of frank symptoms. There may be a florid disease which has come back. So 4S screening is again important. For 1 HP, we will be screening the patient after 1 month. For other adverse effects also, screening is very important. And if at any point of time I find that the cough, fever, and other symptoms have worsened, I will be sending the patient for a CBNAT, for a chest X-ray, and TB diagnosis has to be done. And if found positive, appropriate ATD has to be initiated. Based on DST, we write here, but DST takes a lot of time. So it is a clinical diagnosis. What we do is initially we start with a 4 group of drug. We wait for the DST to come, the report to come. We have to follow up that report. And the decision to modify or the stop the TPT drugs should due to adverse events uh, or to restart it after interruption by the personal treatment must be taken by the physician. Now, the treatment completion, we know that usually with any long-term treatment, there are issues of poor adherence, gaps in adherence. So the target is to complete the 80% of the recommended doses in the expected number of time. So if I have 28 tablets in 28 days, at least 23 tablets should be taken by 28 days. That is the minimum target. At least 144 tablets should be taken by 180 days. So similarly, for 4 hour, 96 tablets should be at least taken by 120 days. That is the 80% of recommended doses have to be taken. But what about the rest 20% doses which were not taken? Our target is to complete the 20% rest doses by 1/3 of the time. That is, if the initial time was 30 days for 1 HP, we will try to complete the rest of the doses by 40 days. If the initial time was 6 months for 6H and 6 levofloxacin, we will try to complete it by 8 months. If the initial time was 4 months, we will complete it by 6 months. So we will give that patient a 2-month grace period for the 6-month courses to complete his or her regimen. And for the 1-month courses, we will give a grace period of another 10 to 12 days. But by that time, the rest of the tablets which were not consumed have to be taken. The management of the missed doses, this is a bit difficult to understand initially. Uh, Less than 1 week if the patient has missed, and if more than 1 week, what to do? Now, if it is less than 1 week, just complete the doses. Like if that 80% dose has been taken, just take the rest of the tablets. Suppose if the patient has not taken the ART for 6 days. So 80% of the doses are not taken. So what we do is we give those 6 days plus another the rest of the days. So what we do is we complete the treatment by 28 and then we give another 6 days medicine. For more than 1 week, again, similarly, we resume the TPT immediately and then we add the missed doses to the total treatment to complete the course within a maximum of 8 weeks from the first dose. So what we are doing here is basically we are seeing that if the 80% tablets are taken, just give him the rest of the tablets. If 80% tablets are not taken, then give him a grace period and ask him to add on to those tablets. Okay, with the total treatment duration. Now, if the more than 7 consecutive doses are missed, consider restarting the complete course of 1 HP because 1 HP is a 4-week course. If more than 1 week is missed, then start it afresh. Now, if the adherence is not possible, I have found that it's very difficult to continue the regimen, then stop it. Now, coming to the 6-month and the 4-month regimens, resume the TPT immediately after return and add the number of days of missed doses to the total treatment if the interruption is less than 2 weeks. But if the interruption is more than 2 weeks, then if the 80% of the doses have been consumed, complete the remaining. If less than 80% have been consumed, the treatment course can still be completed within the expected time for completion. That is, I will give him or her another 2 months grace period and complete the remaining treatment doses in the grace period of time. Okay. So, and if less than 80% of expected doses were taken and the treatment course cannot be completed within expected time, consider restarting the full TPT course. So if we really don't have that much of time because the patient has come after such a long period of gap, then we will restart the course. Now coming to the possible adverse reactions, we are all acquainted with it. INH, we usually have peripheral neuropathy, hepatitis, and the lethargy, also psychosis. Rifampicin, usually we have hepatitis, thrombocytopenic purpura, cutaneous reactions, and the discoloration of body fluids. Rifapentin also similarly, hypersensitivity reaction is common, and the discoloration of body fluids. And levofloxacin, usually we have the diarrhea, and the GI symptoms are the greatest. Now coming to the management of the adverse reactions, TPT must be immediately discontinued for severe adverse reactions, and for mild to moderate, we will treat the patients and we will try to treat through the TPT. We will not stop it. Now the special situations, INH and rifampicin may have hepatotoxicity, as we know, and as I said, the SGOT, SGPT, if it is more than 3 times of the upper limit of normal in the presence of symptoms, we will stop the TPT or defer it. If it is more than 5 times in the absence of symptoms, that is more than 200 or 210, then we will stop TPT. Now we have to look into the ALT or AST, and for that a baseline value always helps. If it is a case of acute hepatitis and any type of acute viral hepatitis, E, A, D, or whichever, then we have to defer TPT. We cannot give TPT along with acute hepatitis. And also with the PLHIV, with the HCV co-infections, rifamycins like rifapentin can decrease the blood level of the drugs that are given, that is sofosbuvir, daclitazvir, we cannot co-prescribe. So we will wait for the HCV treatment to be completed. Now, well tolerated 1 HP and 6H with a chronic hepatitis B virus infection. So there is no contraindication with that. For renal function, we know most of the ATD drugs are cleared by the liver. So if there is a biliary secretion, no issues with the renal functions. TPT can be given in standard doses with impaired renal function. Pregnancy, TPT is not contraindicated, only rifapentin, that is 1 HP, is contraindicated. And now isoniazid and rifampicin are considered safe for use in pregnancy. Can be started during antenatal and the postnatal periods. There is no limited data. This is because with pregnancy and rifapentin, we do not have a solid database, and that is the reason for avoiding rifapentin in pregnancy. And we have to remember that vitamin B6 co-prescription is also very important. And contraception and TPT, rifampicin and rifapentin interact with the hormonal contraceptives. We have to remember that the hormonal contraceptives are again a group of drugs which are the basically cytochrome P450 inhibitors. So what happens is we cannot give these two groups of drugs together. The risk of decreased contraceptive efficacy, the contraceptives will not work. So it is best to go for some other alternative form of contraception like the Perrier or the intrauterine devices. And the interval of replacing the implants, if a woman is replacing her intrauterine implant every 3 months or 12 weeks, that duration of interval of replacement might be shortened in presence of the TPT, that is the TPT with specially rifapentin. Now the babies born to mothers with TB disease, as I said, if a newborn is not well, refer him to a specialist. If he has a contact, then first I will exclude active TB disease. And the basic signs, there are lots of signs like the child is not breastfeeding properly, he or she has hepatosplenomegaly, and the persistent cry. So these children need to be, the gastric lavage may be done, for a sputum collection has to be done, and the TB active disease has to be eliminated. And if the mother is taking TB drugs, we can always continue with the breastfeeding with the mask and the cuff etiquette. Now, TPT among people who are IDUs or the drug users, here also we have to keep in mind about the methadone and the buprenorphine, that is the substitution therapies, because there is a chance that the buprenorphine or the methadone. When we are taking the dose of methadone and the buprenorphine, like they might increase when they are taken with the rifamycin group of drugs. Okay. And the 6H is the INH is comparatively safer, just apart from the liver toxicity monitoring. But if we have to remember that the uh, IDUs who are on OST, that is the substitution therapies for methadone and the buprenorphine, they are not to be considered as a blanket denial for TPT. We should not do that. We have to monitor for the opiate withdrawal symptoms and other adverse events. And we have to increase the dose of methadone or buprenorphine, because as we know that the rifampicin group of drugs are the inducers, and the methadone and the buprenorphine doses might be lessened. That is, the area under the curve will be less. So to relieve the patient of the withdrawal symptoms, the physician has to think about increasing the dose of methadone, increasing the dose of buprenorphine when given with INH. I'm TPT, that is rifampicin and INH. Now, recording and reporting, the green book, we have these and in the search we have to record and report that a patient is getting TPT. And along with that, the white cards also, we have a section 8 for the prophylaxis for the TPT, and yes or no, or and also with the regimen and the start and the completion dates and the NICSHA ID. And as per the action point from the state wise thing, that is, they have to look into the estimated number of eligible, how many are to be given TPT, and about the supply management. And basically the SACS has to rule out the like the stocks. Like, it shouldn't happen that I am starting my patient on INH and I have to really worry about how to continue after 4 months or 3 months. So that has to be looked by the administrative section. And it is always best that if I am starting one patient on IPT for 6 months, then I keep the reserve drug for him or her before starting another fresh patient. And with 1 HP, these hazards about the supply management is much less, and that is the reason NTP is popularizing 1 HP, because it's a 28-day course. And so the supply management, the gaps in supply are less hazardous. Those are lesser worries which have to think about. And the capacity building of the ART center staff is important. Good counseling about the prophylaxis, why patients need prophylaxis, what are the programmatic things, why India has so many latent tuberculosis patients, the contacts, the people who may be contacts, who people who are having history of travel, prisoners, the homeless shelter people, and the PLHIV, also the poorly controlled diabetics. These are all immunocompromised patients, and they have high chances of having active disease from latent infection. So it is very important that our ART center staff really know it well, that why to give IPT or TPT, and how to give it, and how to counsel and observe a patient during the course of the treatment. And that's a summary of all my discussion today. Hope I was understandable. And if any queries, you can always write to coestm1@gmail.com. I would be happy to discuss about the queries. And thank you.
Thank you so much, ma'am, for facilitating this important session. Any queries from the participants? You can now unmute or you can put your questions in the chat box.
Thank you, Sweta.
Thank you, ma'am. Yeah, any questions from the participants? Ma'am, I don't think there are any
Okay,
questions.
fine. No
Thank you
issues.
so much for
Yeah,
facilitating this session, ma'am.
you're welcome, Sweta, and thank you for assisting in the because we had a lot of problem today.
No issues, ma'am. No issues.
Okay,
No issues.
thank
Thank
you.
you so much, ma'am. Thank you to all the participants for patient listening. We'll conclude the session now.